welcome to the June issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. We continue with our updated format, separating the cosmetic portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Spotlight, will feature in-depth summaries and discussion on a few articles chosen by the feature editors. The second episode, Rapid Pearls, will cover the remainder of the journal, with the editors briefly covering clinical application of the data from each article. Our goal with this change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for June are Isabela Jones with Virginia Square Dermatology, who will be providing the article summaries, and George Hruza with Schweiger Dermatology Group, who will provide expert commentary. Thank you for listening. We hope you enjoy this new format, and as always, have a happy surgery day.
DermSurgery Digest podcast. Today we are covering the cosmetic and general dermatology portion of the June 2026 issue of Dermatologic Surgery. I am Isabela Jones, a medical and cosmetic dermatologist practicing in Arlington, Virginia. I'm very pleased to welcome Dr. George Hruza as the featured guest today. While he needs no introduction, Dr. Hruza is a world-renowned dermatologic surgeon, past president of the AAD and ASDS, and currently serving as a member of the Missouri House of Representatives. We are extremely lucky to have him join us today. In this Spotlight episode, we have selected 4 articles to discuss in more detail. We are going to jump into our first article titled Photographic Assessment of Cosmetic Outcome in Post-Surgical Facial Scars Favors Rapidly Absorbable Polyglactin 910 over Fast-Absorbing Gut, a blinded randomized clinical trial by Luis Pantalena and David Slotney. So this was a prospective randomized evaluated blinded trial conducted on 105 patients having Mohs surgery on the face. All defects were closed with a buried polyglactin sutures, but the patients were then randomized to have epidermal running sutures with either 4.0 or 5.0 polyglactin sutures on one half of the defect, or fast-absorbing plain gut sutures on the other half of the defect. At 6 months, analysis by a dermatologist and plastic surgeon overall favored the polyglactin side without any difference in the rate of adverse events. The authors mentioned that polyglactin is about 20% less expensive and tends to be less inflammatory than fast-absorbing gut. For Dr. Hruza, as a Mohs and as a laser surgeon, you are especially well equipped to comment on this article. I was wondering, whether you use absorbable epidermal sutures. What's the most common way that you close defects on the face? And do you have any thoughts about this article?
Mm-hmm. Well, I do use absorbable sutures for the skin. I really started using them mostly during COVID to reduce number of post-op visits. So that's when I really started using it. Before then, I used it for skin grafts because taking sutures out from skin grafts, sometimes you disrupt the graft. So I felt it's better to have absorbable there. If I want the optimal outcome, I do still tend to prefer Prolene over nylon or any of the other sutures because it is so non-reactive. So when they come back at a week, there's no redness, no swelling, nothing at all. You can hardly tell except for the blue of the suture. But nowadays I do use almost for primary closures on the face. I will use the 5.0 fast absorbing gut is what I've been using. But after reading the article, the Vicryl being the fast rapid Vicryl, or what is it called? Vicryl Rapide, I think it's called. I would think that would be. I'm definitely going to try it because 20%. If it's really 20% less, then I'd go with that. If you read the article, I know they try to make a big deal of the difference, but if you really delve into it, the plastic surgeons didn't find a difference, and the dermatologists did on a couple of measures, not on others. if you look at the picture where they said that the Vicryl was better, I looked at the picture and the results were awesome on both sides. And I think that's why you really can't tell the difference, because they clearly do good surgery, and so they got good results. So I think meticulous technique is more important than which of these type of sutures you do. I was a little surprised that I would never use a 4-0 suture on the face. So I don't know where they were putting that, because I think that would cause a reaction. I find both tend to be somewhat reactive. Chromic gut certainly is. I mean, not chromic, sorry. Fast gut is definitely more absorbable. The one thing that I have gone away from, I initially tried to use 6-0 fast gut on the face and found that not very good, because usually the needle it has is really not very good, gets dull very quickly. It tends to break easily and also dissolves too fast. So sometimes fast absorbing is too fast. And that's so I've also, for example, on flaps, I will always use a proline, because I want to see the patient back anyway. So then I will use the proline on there. But the one other pearl that I do in order to save some of the cost is that you can do, and we did a paper on that that showed no difference between using monocryl versus nylon, proline. And we found no difference over time. And by using monocryl, you still have to remove it because that's too long lasting. But you use the 5-0 monocryl for deeps, and then 5-0 monocryl on the surface. So one suture for smaller defects will take care of it, and suture is your most expensive item. So yeah, so I'd say go with the one that you can get for lower cost.
Right. And then just curious, when do you see patients back? You know, if you're using an absorbable epidermal suture, are you having them come back after a month? What's your usual policy?
So since we started using these absorbables, if it's I just do for primary repairs, I usually don't have them come back unless they're having a problem.
Right.
Now, realizing how the coding is and what the relative value scales and all that global periods, you know, one should see the patient one time back in the first 10 days. But that's how the code is made.
Right.
But we do have a lot of patients that come from pretty far away, and as many of us with their referral practices, and so it is quite inconvenient for them to get back into the office.
Absolutely. Absolutely. Well, thank you for that. Okay. Our next article, it was a very lengthy article and fascinating, but it's titled Regenerative Aesthetics, Present Advances and Emerging Strategies for Optimized Tissue Health by Leda Catalan and Sabrina Fabi. Regenerative aesthetics is a field of medicine that attempts to target the biological mechanisms that are at the root of tissue degeneration. The authors conducted a literature review of 74 articles and aimed to explore emerging therapies in regenerative aesthetics. This is a difficult paper to summarize in 1 minute, and I highly encourage our listeners to read through it. The article also includes multiple useful tables. Overall, the authors identify 3 main pillars in regenerative medicine. Pillar 1 are cellular treatments, specifically stem cells like adipose-derived stem cells, stromovascular fraction, and nanofat. The second pillar are biochemical cues like exosomes, nucleotides, and peptides. Specifically, polydeoxyribonucleotides and polynucleotides exhibit significant tissue repair and anti-inflammatory effects. Polynucleotides also serve as scaffolds for tissue volumization. Exosomes demonstrate therapeutic potential in wound healing, pigmentation disorders, and skin rejuvenation. The third pillar are scaffolds, which are materials that provide structural support and stimulate tissue repair and extracellular matrix remodeling, like calcium hydroxyapatite, polyl-lactic acid, hyaluronic acid, polydioxanone, and allograft adipose matrix. The authors also touch on new data suggesting that polyl-lactic acid may increase adipose-derived stem cells. For Dr. Hruza, this was an illuminating article, at least for me, and I bet many of our listeners are going to be hearing about these therapies for the first time. I personally use quite a bit of PLLA in my practice, which the authors kind of categorize as a scaffold. Do you have, any personal experience with any of these therapies? And do you have any sense of maybe which of these therapies will become more popular in the future?
Well, I do have a lot of experience with the polyl-lactic acid, of course, hyaluronic acid, and the hydroxyapatite. And we've used that for many years, and that, of course, works well, and it's pretty well understood how those operate. The question really is on all these other methods where you've got it, to me, is a little bit of a feeling of a Wild West kind of situation. I mean, the studies are all over the place. There's no dosing specificity. There's so many different chemical components. So I don't really have an answer. I think the ones that are, to me, the stem cells are the most interesting just outside, because outside of dermatology, it certainly seems to work well. If you put it near its whatever the original structures, it seems to differentiate into that. So for joints, it works quite well. It seems to be very promising, even though it's also a little concerning because stem cells, are potentially can be not just differentiated, but can also multiply. So you kind of worry about potential issues of out of control growth. It hasn't been seen yet, but there's the one caveat. Challenge with stem cells is that you can't really patent them, and so it becomes up to each individual group that decides to use them. So, but I think those are interesting, and as long as it's your own stem cells, I think putting them into the skin, that's okay. I think going outside of that, I think you want to be careful. Then we get into the exosomes, the peptides, DNA and RNA type of stuff. Those are all very similar because exosomes really just contain these other molecules. So it's just the packaging. They may work if they are injected, but we don't know what's going to happen and what kind of reaction you're going to get. Especially some of the peptides and so forth are not necessarily that individuals. Those are purified from other settings, so then you get antigenic effects. And so you got to be really careful if you start injecting something like that, which has not been tested. So I think using these so if you're doing injectable type of stuff, it's got to be done in a controlled study, kind of FDA, under FDA kind of guidance. If you're applying it topically, if it's on open skin, then I think you have the same issue. So if it's like post-resurfacing, if you're doing it on closed skin, so it's just, like Retin-A we use for rejuvenation, it probably won't do very much because these tend to be longer, big enough molecules that they're really not going to get through. So unless they can figure out a way to get those through the skin. So there's a lot of unknowns there. So because you can see, I don't know which one, where it's going to go. I think the stem cells, to me, are the most exciting because they have the potential to really, truly rejuvenate. If you think about if you're going to get it into the skin and it's going to be near the fibroblasts and it's going to start growing collagen or elastin and all that, which is great. The other ones are molecules, so they can be used sort of as a filler, but I don't know, do we know that they're going to stimulate the existing cells to do stuff? The stem cells can do it themselves. So So to me, that's the most exciting.
Yeah, and I think, many of these things are maybe more talked about in the past, even just 2 to 3 years. So I think I'm hoping in 10 years we have better studied products, understand safety profile. I've noticed a lot of medical spas in at least my area already kind of dabbling in these things, but as a, dermatologist who practices evidence-based medicine, I'm
Yeah.
certainly going to be waiting.
Yeah. So yeah, exactly. I think it's with time we'll see where it goes. So I guess I'm not quite the cowboy that I'm going to go and start doing them now. On intact skin, it's fine, but as I said, if you start injecting this stuff, then you got to be really be more careful with it.
Absolutely. All right. Our third article is titled, "Does prior treatment with facial injectables increase the risk of rhytidectomy complications?" by Jennifer Salzberg and Demetrios Matakis. This was a retrospective review of all patients undergoing a deep plane rhytidectomy by a single surgeon over a 15-month period. Of 106 patients ages 40 to 80, 57% had prior injectable treatments with either hyaluronic acid, PLLA, or calcium hydroxyapatite. While 24% of patients had complications after surgery, there was no difference in the complication rates between patients who had or had not had prior filler. Surgical times were similar between the two groups. The authors mentioned several weaknesses to their study, including small sample size and imperfect recall of the type of filler used and injection locations. Dr. Hruza, many surgeons, on social media are outspoken that they discourage their patients from pursuing non-invasive treatments like poly-L-lactic acid, calcium hydroxyapatite injections, all of which they believe may cause scar tissue that complicates future surgical procedures. How do you talk to your patients about these concerns, especially in light of this article?
Well, so first off, just looking at the article, I was surprised at the very high rate of complications because they were, it was, and actually it was even higher in the patients that had that did the PLLA or calcium hydroxyapatite.
I think it was like 16 versus 8, right?
Well, yeah, but that's actually, that's how I initially thought of it, but actually it isn't like that because that's using the denominator was the wrong denominator. It's actually was like 20 some percent in the non-PLLA and the group, non-filler group, and it was like more than 30% in the group that did have fillers. So. But it was very high, and the infection rate. I didn't bring my papers here for where I calculated them, but the infection rate was also very high. It was more than 10%. I mean, an infection rate of 10%. That's at least in most surgery and dermatologic surgery, that would be totally unacceptable. I mean, it should be 1 to 2%, and an infection in someone who's a deep plane, I'd be really worried. So to me, that was a bit concerning that they had so much complications. So then I kind of may sometimes question some of the other stuff because clearly they had issues. Now, but it is, I think for a deep plane facelift, there should be no issue really because the fillers are generally put into the subcutaneous plane most of the time. I know that some places we do put it right up on top of the bone, like in the orbital, in the lower eyelid area. I kind of put it deep there, but most places on the cheek it does go into the fat compartment, and some places you may even go more superficial depending on where you're going. The other thing is it depends on where you put the filler. So for deep facelift, it should make no difference. When you're doing a traditional facelift, then I would say a mini facelift it also wouldn't make a difference because the undermining only goes part way out, and then you pull the SMAS, and so you don't really you're not undermining all the way to really the areas where you put the filler, which usually is toward the center of the face. Now, I know that sometimes people do put it in their in front of the eye, in front of the ears, and I've even had a patient where I was doing a repair, and I guess I didn't get the right history, and I did not know that they had a filler, and I kept thinking there was a cyst there, and so I was doing, closing the thing up, and there was this white stuff kept coming out. So I said, well, I can't just close this because that's just going to, get inflamed and infected cyst. So I kept going and going and going and getting more and more stuff out, and finally we figured out that this was actually, it was, I think, hyaluronic acid filler, I think. Anyway, so that, but that's not the fibrosis part. So it's true that the fillers, especially the scaffolding ones, but it turns out, I think, even hyaluronic acid fillers, because there's some studies now that show that even 2 years later, 3 years later, you can still find evidence of the filler. So even those probably cause some fibrotic changes. It may change the undermining. When you do the undermining for the facelift in the area where there was filler, it's just going to feel more like a redo facelift, where you're going to have a little bit more bleeding, the skin is stiffer. So that is kind of a negative overall, not just for facelifts. I mean, that's what fillers do. They do cause fibrosis, which causes tightening, because there's contraction, you get myofibroblasts. So it's kind of like an expected effect, which then when you do a facelift, makes it more difficult because now the skin is stiff and just it doesn't undermine so easily with just the scissors. Just kind of just go in there, snip and separate, and it just all moves. So so I guess I tell patients, if you're gonna have a facelift, then you've got to think about which fill you put in. Then I would probably still rather recommend the hyaluronic acid one, because then if you're gonna have a facelift and the surgeon doesn't like you having filler, well, gee, you can put some hyaluronidase in there, where the patient had the filler, do the facelift, and then put more hyaluronic acid. So I don't think it's an absolute contraindication. It just makes the procedure probably a little bit harder, but not that, you kind of have to live where you are in the present, so.
Correct,
If you're
yeah.
getting filler when you're 30 or 40 years old, you're not necessarily going to say, well, I'm not going to do filler because when I'm 50 or 60, I may want to do a facelift. I just don't see that.
Correct.
It's not that bad.
And I tell patients too, at least myself, that, with the way we're injecting, at least me PLLA mostly subcutaneously, that, staying far away from fascia and, bone, personally am. And I say, if we're thinking about a facelift, probably in the 2 to 3 years before that potential surgery, we'll take a break from these procedures, just to reduce maybe the presence of some of that scar tissue.
Yeah, exactly. So yeah, so do what's right now, basically. That's where we live anyway. There's the immediacy.
That's maybe a motto for life. Like do the
right.
best with the information you have now.
Right.
Well, our last spotlight article, number 4, is the safety and efficacy of a multi-use neurotoxin protocol in academic settings by Michael Shaughnessy and Anna Barr. This was a retrospective review of all patients receiving onabotulinum toxin A for cosmetic purposes over a 5-year period at Oregon Health and Science University. Per Allergan, vials of Botox are for single use and should not be stored for more than 4 hours after reconstitution. At the study institution, Botox was used as a multi-use vial, were constituted with 2.5 mLs of bacteriostatic saline, used within 28 days of reconstitution, and stored in a refrigerator between treatments. Of more than 2,600 treatments, 13% of patients had a follow-up visit within 30 days. A total of 1.46% of patients had an adverse event, but none of those included infections. There were no infections reported. The authors argue their research supports the use of cosmetic Botox as multi-use vials, and that this will help reduce waste in academic centers and physician offices. I personally have, private practice now for 10 years, have always used my neurotoxins as multi-use vials. I stored, unused portions for longer than a few hours. I'm curious, during your time in academic institutions, what was the most common practice that you saw, and do you think this article will change policies at these larger organizations?
Well, so this is there are really two parts to this. One part is clinically, practically what people do and what's safe and what I would call, maybe call it standard of care, but basically what it works, it's safe, no patients are harmed. Doing it, keeping it for 28 days, or some people do it for a week or 14 days, and based on their studies and other studies show that when you dilute or reconstitute with the bacteriostatic saline, it's totally safe for that time. That's the clinical part of it, but there's a regulatory part, and so we had USP Chapter 797 was updated about 4 years. It took effect November 2023 was the final change of USP Chapter 797, which all 50 states ascribed to or agreed to or believe is valid. Well, the FDA has also weighed in because of the Aspergillus outbreak. That was the number of deaths from Aspergillus meningitis. And then we had a law that was passed dealing with these kinds of, with sterile compounding, basically, both of topical medicines, but injectables. So the FDA's current rule on it is that you need to follow those kinds of limits, the 4-hour limit. However, FDA has chosen, it's called enforcement discretion, in that they're not going to enforce it in physician offices because it kind of goes into medical practice, which the FDA does not regulate. However, the USP has recommended that if you compound, which is what this is considered, compounding, when you reconstitute it not according to the label, which is not according to the label, then you've got to have to label it and you have to do all kinds of stuff to label the syringe with when you did it, who did it, and so forth, and you have to use it within 4 hours. Now, you don't have to use it on one patient because you've done this compounding, so it's a different situation. I don't think that's necessarily the case. Now, the separate piece is that it is a single-use vial, so a separate rule would say you can only use it on one patient. Mm-hmm. So so even that gets difficult. But if you do reconstitute it with non-bacteriostatic saline, you have to use it within 24 hours. So that's all the rules. Now, the USP, since it's been adopted, now there have been cases where they've gone to doctors' offices and penalized them for it. Really, in this case, it had to do with lidocaine, because people also do lidocaine, buffering lidocaine, and that's considered compounding. So people have been penalized. Ohio has been especially really tough on that, and significant fines and all kinds of problems. So unfortunately, we are all the states at risk of doing it other than the 4 hour, doing it within 4 hours. Now, there's a little bit of light at the end of the tunnel for lidocaine because we have developed a monograph. I was involved in the group that developed it and did all kinds of testing, and USP has accepted it. So lidocaine, once it's published in the JAD, will allow you to keep the lidocaine going for hopefully for 7 days. Once it's published, then it will take effect. Now, that's not going to help us with the botulinum toxin. However, I think it could be used as a model to do the same kind of study with botulinum toxin, which I would say, if anybody from any of the companies is listening, would be great to to do a study, which basically just makes sure that it's not a patient study. It's where you reconstitute it and then you test it basically if there's an infection and so forth.
Mm-hmm.
And there may be an efficacy that it's still effective at 28 days. And if we do get that kind of monograph together, then we could allow it to be reconsidered. And I was going to say again for the companies, because the way these monographs works, it's going to be the exact product. So it can't be just generically any lidocaine. So it's the same way for botulinum toxin.
Mm-hmm.
So if Allergan decides to do this kind of work, it would only apply to their product.
Right.
And they might get a competitive advantage. So there you go. So clinically, I think it's totally safe, but regulatory-wise, there's some risk of getting penalized.
It's marquee. I mean, I'm curious to see too. I know Galderma, right, is going to have a pre-reconstituted toxin. I know it's currently with the FDA. I forget the name of it. It has a cute name, but it'll come in a liquid form already that you don't have to reconstitute. So I'm curious to see what, the recommendations will be with that new product come out.
Which would be great, because as long as it's with preservative, the challenge they have is that if they use it with preservative, they have additional regulatory hurdles because that's another chemical. If there is no preservative, it makes it easier to get the approval. But that would be great. That would give them a leg up, because now if they could sell it as a multi-use vial, that's a game changer, and I would hope that all the companies are thinking of that.
Right. And sort of hopefully eliminate errors in reconstitution and things like that too. Yeah, absolutely. Dr. Hruza, thank you so much for your time today in the Spotlight episode. For our listeners, you can hear commentary and all the other articles in this month's issue on the same podcast platform, or visit the DermSurgery Digest link to the ASDS website. Any final words from your end? Mm-hmm.
I think it's been great. This is great. Hopefully you're enjoying the weather as I am, because I'm going to be going out door knocking, campaigning, and it's beautiful weather after we get done here.
Wonderful. I'm so glad you're doing that.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.